reactive surgical theatre, and straight into the proactive genomic era of gynecology. Let's just dive right in, because the way we look at cancer risk and prevention is fundamentally changing, and understanding this shift is absolutely vital for anyone involved in or affected by women's health.
I really want to anchor everything we talk about today with this one quote. We no longer merely manage a solitary disease event. We manage a lifetime risk. I mean, that perfectly captures the massive shift we're experiencing, right? In the past, a patient would come to me with cancer. I'd surgically treat that one solitary event, and we'd basically just hope for the best. Today, thanks to early genomic identification, we are doing so much more. We are looking at the patient's entire lifespan, and even their biological relatives, shifting from a reactive, after-the-fact treatment model to proactive, lifelong genomic medicine. So, here's our clinical roadmap for today's explainer. We're going to cover the big paradigm shift, why certain cancers act as a sentinel warning, and then walk through the tumor triage workflow and the super important methylation filter. Finally, we'll look at gene-specific surgeries and some hard truths about the limits of surveillance. All right, let's get into it.
Starting right off with Part 1, the paradigm shift from reactive to proactive care. It's basically our professional duty now as gynecologists to actively hunt for inherited cancer predispositions. It's not just some optional extra anymore. It is baked right into routine care. To really get why, we need to talk about Lynch syndrome. It's an autosomal dominant condition, meaning there's a 50-50 shot of passing it on to your kids. It happens when there's a glitch, a pathogenic variant, in the DNA mismatch repair, or MMR system. We're talking about genes like MLH1, MSH2, MSH6, and PMS2. Or sometimes it's an epigenetic thing, like EpCAM deletions shutting down MSH2. When this MMR system breaks, your DNA's spell check just stops working. The result? A massive, literally 1,000-fold increase in mutation rates.
Now you might be wondering, okay, so what does that actually mean for the patient? Well, this is where it gets absolutely fascinating. All that hypermutation drives the creation of cancer, sure, but it also creates a huge neoantigen burden. In plain English, the tumor looks so bizarre to the body that the immune system actually spots it. Because of this strong immune response, these tumors naturally have a surprisingly favorable prognosis. But here's the real game changer. It makes them uniquely sensitive to modern immunotherapies, specifically PD-1 and PD-L1 checkpoint inhibitors like pembrolizumab. So finding Lynch syndrome isn't just about screening anymore, it literally tells us how to effectively treat advanced disease.
Moving on to Section 2, let's talk about the sentinel cancer, or the first warning sign.
Let's see how this builds our understanding of what we do as gynecologists. Gynecological malignancies, especially endometrial cancer, frequently act as what we call the sentinel cancer. They're like the canary in the coal mine. They often show up as the very first malignancy in a woman with Lynch syndrome, way before any colorectal issues appear. And catching this sentinel cancer, it puts us gynecologists in the critical position of being the diagnostic lead. We aren't just treating the woman right in front of us. We are sounding an alarm that triggers life-saving cascade testing to protect her entire family. Let's put some numbers to this to see exactly why we have to be so aggressive. Look at the maximum cumulative risk of getting these cancers by age 75. It is, frankly, alarming. The risk for endometrial cancer? A massive 57%. Colorectal cancer is right up there at 45%. And the chance of developing any cancer over a lifetime? Up to 81%. That's not just a mild predisposition, right? That is a huge lifelong risk that absolutely demands a proactive, strategic game plan, not just waiting around to see what happens.
Okay, Part 3, the tumor triage workflow. How do we filter for this risk?
So how do we actually find out who has Lynch syndrome in a jam-packed clinic without bankrupting the healthcare system? Well, we use a diagnostic funnel. It all kicks off with a clinical history and a good old-fashioned family pedigree. That remains our essential first filter. In the past, we relied on the Amsterdam 2 and Bethesda guidelines. But let's be honest, their specificity for endometrial cancer is pretty low. These days, we rely on the PREM5 model. It's a much sharper prediction tool. If a patient gets a PREM5 score over 2.5%, boom, that triggers reflex tumor-based triage. And if it's over 5%, we send them straight to clinical genetics.
Once a tumor is in triage, we use a really cost-effective two-step pathway. Step 1 is immunohistochemistry, or IHC. We basically look at the tumor tissue to see if those MMR proteins are physically missing. Now, it's absolutely crucial here that our pathologists check for normal, conserved expression in the surrounding stromal tissue. That acts as an essential internal control to prove the test actually worked. Then step 2 is microsatellite instability, or MSI testing. This is a PCR-based test that categorizes the tumors based on their DNA stability. If it comes back MSI high, we are highly, highly suspicious of Lynch syndrome.
Which brings us to Section 4, the methylation filter, and how we rule out somatic changes. This right here is our ultimate triage checkpoint. And let me tell you, it is a total game changer for saving patients from unnecessary panic. See, a lot of tumors will show a loss of the MLH1 protein during that first IHC step. But here's the catch. That loss might just be from somatic hypermethylation. In simpler terms, it's just a random mutation isolated only to that specific tumor, not an inherited genetic condition. So the MLH1 promoter methylation test is the key. If this test shows somatic hypermethylation, it effectively rules out inherited Lynch syndrome. We can look the patient in the eye and reassure them that their family is not at risk, sparing them the stress and the cost of full germline genetic testing.
Now, if the methylation filter doesn't rule it out, we have to get a definitive diagnosis using next-generation sequencing, or NGS. A quick clinical pearl for you here: sequencing the PMS2 gene is notoriously tricky because of these structural pseudogenes, so it really needs to be sent to a specialist center. And I literally cannot stress this enough, especially to my junior colleagues out there. Sometimes NGS comes back with a VUS, a variant of unknown significance. These are strictly managed by geneticists. You must never, ever base a radical, life-altering surgical decision on a VUS. Just don't do it. All right, Section 5, gene-specific surgery, turning all this data into actionable prevention. Once we actually have a definitive pathogenic diagnosis from that NGS test, our entire focus shifts to lifelong, actionable prevention. And the beauty of genomic medicine is that it gives us highly specific timelines for our gold standard intervention. Once a woman has finished having her family, we recommend risk-reducing surgery, specifically a total hysterectomy and bilateral salpingo-oophorectomy. But we don't just use a one-size-fits-all approach. For MLH1 or MSH2 carriers, we aim for age 35. For MSH6, it's age 40. And for PMS2, where the risk develops quite a bit later, we wait until 50. This precision means we aren't throwing women into surgical menopause even one day earlier than absolutely necessary.
But hey, surgery isn't our only weapon here. We've got some really solid non-surgical tools too. Take aspirin, for example. The high-quality CAP2 trial gave us fantastic data firmly supporting regular aspirin use to reduce all cancer risks for Lynch carriers. We also use hormone-based therapies, like the Miranacoil or oral contraceptives, to actively keep the endometrium from overproliferating. And of course, targeted lifestyle modifications, managing weight, quitting smoking, cutting back on alcohol, are totally vital for bringing down those baseline risks. Finally, Section 6. Let's talk about the limits of surveillance and some of the hard truths we have to face.
This is the part of the clinic visit where I have to be radically candid with my patients about monitoring for gynecological cancers. I want you to look at this number, 90%. That is the astonishing 10-year survival rate for Lynch syndrome-associated endometrial cancer. Because these specific tumors often cause symptoms like bleeding very early on, and because, as we mentioned earlier, they are highly immunogenic and naturally have a favorable prognosis, patients actually do incredibly well, even without getting continuous invasive screening scans.
And that leads us to a pretty stark reality check. On one hand, you have risk-reducing surgery, the absolute gold standard for prevention once a family is complete. On the other hand, you have gynecological surveillance. We're talking transvaginal ultrasounds, painful regular biopsies, checking CA-125 levels. The hard truth, this kind of surveillance is highly controversial. Why? Because it just hasn't been proven to improve survival outcomes compared to simply waiting for symptoms to show up. A lot of the time, relying solely on these scans just gives women a false sense of reassurance, while putting them through a ton of anxiety and highly invasive appointments for no real benefit.
But I need to make a really sharp distinction here. While the gynecological surveillance is kind of limited in terms of survival benefit, we have to emphatically remind our patients about their bowels. Getting a colonoscopy every 2 years is the absolute non-negotiable bedrock of managing colorectal risk in Lynch syndrome. We absolutely cannot let the nuance of gynecological monitoring distract us from the strict necessity of regular colonoscopies. They literally save lives.
Ultimately, taking care of a patient with Lynch syndrome means taking care of the whole person across their entire lifespan. Since cancer risks skyrocket after age 40, we have to initiate proactive family planning conversations when these patients are in their 20s. We offer options like pre-implantation genetic testing, or PGT, so they can actually choose to select embryos that don't carry the pathogenic variant. Plus, when it comes to surgery, our strikes need to be perfectly coordinated. We team up with a colorectal surgeon so we can synchronize a hysterectomy with a bowel surgery or colonoscopy.
It's all about intentionally minimizing the number of times that patient has to go under general anesthesia.
The shift from just reacting with surgery to proactively using genomic medicine is, without a doubt, the most exciting evolution I've seen in modern gynecological oncology. By catching that sentinel cancer, filtering the risk accurately, and jumping in with precise, gene-specific interventions, we aren't just saving the life of the patient in front of us, we are quite literally protecting their entire family tree. So I want to leave you with this final thought to consider. As genomic medicine becomes the absolute standard of care, how will early identification reshape the future of your family's health? Thank you so much for joining me in the clinic today for this explainer. I really hope this empowers you to ask the right questions and take full control